Hey everybody, so we're going to talk about ARDS, Adult Respiratory Distress Syndrome, or otherwise known as Acute Respiratory Distress Syndrome, because it can happen in children as well. This is just to distinguish it from neonatal respiratory distress syndrome, which of course is a deficiency of surfactant, and that's much different. So, acute respiratory distress syndrome is acute respiratory failure. It is classified as a restrictive pulmonary disease, as an interstitial lung disease, but it's obviously very different from the other interstitial lung diseases, and that this has a very acute onset. And it always follows a systemic or pulmonary insult, whether we know what that insult is or not. Now, normally, or I should say the number one cause is sepsis, or some kind of infection. So that would be your number one suspicion if you have a patient with ARDS. Now, usually you're not going to know that the patient has ARDS until after you get the chest x-ray. However, there are some signs. We'll talk about those. But the number one cause is sepsis or some kind of bacterial infection. They certainly don't have to be septic shock. It could be pneumonia. It could be a wound infection, but some kind of bacterial infection. Chemical and gas exposure could be another thing. Smoke exposure, for instance. Trauma, like head trauma. Burns, gastric aspiration, near drowning. Acute pancreatitis, and transfusions can be other causes. Particularly with near drowning, you're talking about massive water aspiration. So what happens with ARDS is that this trigger, whatever it is, results in a rapid and widespread pulmonary edema, and that's because the alveolar capillary membrane has been altered. So some kind of trigger has caused the alveolar capillary membrane to become disrupted, and that's letting water into the alveolus. It's letting the natural blood pressure in the capillary is pushing water into the interstitial space, and that's reducing the ability of oxygen to diffuse from the alveolus into the capillary. So the result of that is that we have reduced oxygen diffusion, and therefore we're going to get a reduced saturation level. This may be accompanied by other organ system failure, where you would think about that is, for instance, the inflammatory response system that you would see in sepsis. So if you have a septic inflammatory response syndrome, SIRS, then you may see other organ system failure. That's just going to, though, depend on what the trigger is. So if you have acute pancreatitis, yes, you're going to see abdominal pain, back pain. If you have smoke exposure, then you're going to see soot around the face and so forth. So just to keep in mind that ARDS is not seen in a vacuum. It's not necessarily a diagnosis in and of itself, but rather a complication of other things that are going on somewhere. The major differential diagnosis is cardiogenic pulmonary edema, which I devoted an entire talk to much earlier. And the reason for that is just based on the pathophysiology. So what happens in ARDS? Something happens, and you get an increase in, you get a leaky alveolar capillary membrane. So some kind of biochemical process is happening which results in water moving across the alveolar capillary membrane. With cardiogenic pulmonary edema, it's sort of similar, but due to different causes. So with cardiogenic pulmonary edema, you've got congestive heart failure, and now you've got an increased pressure in your capillaries, and that's pushing the water out. Just because of the increased pressure. So one is because of a leakiness in the capillaries, that would be ARDS, and the other is due to elevated pressure in the capillaries. So they're different, but they will appear the same because you're getting the same kind of result, and that is pulmonary edema. Pulmonary edema is seen in both ARDS and in cardiogenic pulmonary edema. So the history behind ARDS is a known or an unknown trigger. Most often it's an infection, possibly some kind of pulmonic or non-pulmonic trauma. The symptoms are going to be labored breathing, intercostal retractions, tachypnea, crackles and rails on auscultation, anxiety and agitation. So think about what's going on here. You've got water in the lungs. You're drowning in your own lungs. So you're going to be you're going to have an increased respiratory rate because the respiratory drive is going to be higher because you are less oxygenated. Your breathing is going to be labored because your lungs are supposed to be light and airy, and now they're doused in water. Intercostal retractions is just a result of respiratory fatigue, and then the crackles and rails on auscultation is just hearing the fluid in the lungs. And then anxiety and agitation is a normal response to low oxygenation. Okay, so physical examination. On your vital signs, uniformly you're going to have low saturation levels, definitely below 90, often even with supplemental oxygen. So you could have a patient on 6 liters of nasal cannula flow and they're still going to be saturating in the 70s or 80s. That's a clear sign of some kind of pulmonic disease, obviously. They may also have a fever or hypothermia, especially if it's an infectious source. If they do have a fever or hypothermia, you should definitely be thinking of an infectious source. And of course, there might be cyanosis signs present. And by cyanosis signs, I mean acute cyanosis signs. So blue lips, blanching, and so forth. Not talking about clubbing of the fingers. The best initial step is always going to be to stabilize the patient, and usually that's going to ultimately mean intubating the patient, usually with PEEP. However, in the interim, nasal cannula or mask ventilation is better than nothing. But usually with ARDS, it's going to be heading towards mechanical ventilation. What we need to do is we need to bring the saturation levels above 90. That is always our goal. As far as making the definitive diagnosis, the best initial test, it's kind of hard to say. You do need a chest x-ray in order to diagnose ARDS. That's certainly necessary because you need to see the infiltrates, but you also need ABGs to diagnose ARDS because there are criteria for ARDS based on your PaO2 FiO2 ratio, which we'll talk about in a little bit. So both of those are vital tests to have at the very beginning. I don't imagine you'll be asked on the USMLE which of the following is the most important, or which of the following is the first diagnostic test, unless it excluded one of these, because they're both going to be important to get right away. Now, when you get a chest x-ray, the first thing you're going to want to do is to differentiate cardiogenic pulmonary edema. We want to know if this is ARDS or if this is due to congestive heart failure. Certainly, you can have patients who have ARDS who also happen to have congestive heart failure, and you want to know if this is a reaction of their congestive heart failure or if it's due to ARDS. And the way you can differentiate that is with your BNP levels, brain natriuretic peptide. If your BNP levels are high, then that points to cardiogenic pulmonary edema. If they're low, that points to ARDS. So, diagnostics. The ones I put in red here are the ones you need to have. So, chest x-ray, it will show bilateral pulmonary infiltrates, and the cardiac silhouette should generally be normal, and that's of course barring the fact that they don't have any other valvular problem or congestive heart failure, but they should have a normal silhouette. On your ABGs, your PaO2, partial pressure of oxygen, is always going to be low, and your partial pressure of CO2 may be normal or high. Your BNP is going to be normal, assuming that you have ARDS, and The BNP is not necessary to get right off the bat, but I would get it if the chest x-ray shows an enlarged cardiac silhouette, because then in that case, if you see an enlarged cardiac silhouette, you don't necessarily know if it's ARDS or if it's cardiogenic pulmonary edema, because in cardiogenic pulmonary edema, you're also going to have pulmonary infiltrates because you've got fluid going into the alveoli. So I would refrain from getting a BNP until you see a chest x-ray that shows an enlarged cardiac silhouette, because if the cardiac silhouette's normal, you don't need it. A normal level, of course, as I mentioned, indicates the absence of cardiogenic pulmonary edema. Another thing that you can get, certainly you don't have to, but you may get it to definitively rule out cardiogenic pulmonary edema, is the pulmonary capillary wedge pressure, and all this is a reflection of the left atrial pressure. And normally it should be below 18 millimeters of mercury. That's a magic number you should know for the test. And if the PCWP is normal, then that indicates an absence of cardiogenic pulmonary edema. The PaO2 to FiO2 ratio is just your basically exactly what it says. So your partial pressure of oxygen in your artery divided by your fraction of inspired oxygen, and that should be, the new criteria is now below 300. We've actually eliminated the concept of acute lung injury and just lobbed it into ARDS. So this is actually old criteria here. So this should be less than 300. Anything less than 300 is considered ARDS. We've gotten rid of the concept of acute lung injury. So it's all ARDS now. So less than 300. So this is a chest x-ray of a patient with clearly no enlarged cardiac silhouette. Remember that the rule is that the transthoracic diameter of the heart should be no greater than half of the transthoracic diameter. I didn't say that right. The width of the heart should not be any more than half of the transthoracic diameter. Okay, and this clearly is not. So this is a normal appearing heart, and we've got these bilateral pulmonary infiltrates. Here's another one. This one's kind of verging on maybe a little bit enlarged. So maybe get the BNP here, but it's close to normal. And this one's definitely a normal heart size, but you've got a lot of infiltrates. So how do we treat ARDS once we've diagnosed it? Well, the therapy is going to be focused on the underlying cause, because that's what's actually causing the ARDS. And then, of course, we want to make sure that the patient is ventilated, because that's all part of our ABCs. So usually the underlying cause is sepsis or some kind of bacterial infection. So we're looking for any possible source of infection, be it a wound, be it meningitis, be it pneumonia. We need to be looking at all of that. So you're going to be getting blood cultures, you're going to be getting sputum cultures, you're going to be getting a lumbar puncture if you need to. Usually the cause should be somewhat straightforward, but you're definitely going to be pan-culturing the patient. Urine cultures, etc. As far as ventilating the patient, it's generally going to be mechanical intubation. I can't imagine a case of ARDS where they're not mechanically intubated. We use PEEP, which is positive end expiratory pressure. And what we do with it, and this is sort of ancillary information for real life. I don't know how deep the USMLE goes now in expecting you to know information about ventilators. But what you want to do is you want to with PEEP, what you get to do is you can the advantage to it is that you can monkey around with the pressure so that it provides a certain partial pressure or a certain fraction of oxygen. So with your nasal cannula, you can only go up to about about like 50% FiO2. With your PEEP, you can go up to 100% FiO2. You can give them 100% oxygen. So that's the advantage to it. What you want to do, though, is you want to give them just enough of a fraction of oxygen so that you're keeping their saturation above 90. Because if you give them too much, you can actually induce oxygen trauma, and that's going to present more problems. So you want to titrate up their FiO2, and you do that by titrating up the pressure, which is measured in centimeters of water, and you titrate that up to keep their saturation above 90. You're also going to be wanting to get frequent chest x-rays and ABGs to monitor their resolution. That's going to be how you monitor their progress, which should be improving, provided that you're actually treating the underlying cause. The therapeutic goal, the big milestone, is after 48 hours of having them on PEEP, that you're able to reduce their FiO2 down to 60% and keep them saturated above 90%. So you can have their FiO2 wherever you want at the beginning, but the goal is after 2 days that we're able to maintain them saturated above 90% on an FiO2 of 60%. And ultimately, we wean these patients off as quickly as we can and as safely as we can. The longer you're on a respirator, the more risk you are to get respirator-associated illnesses. You can get ulcers from being on a respirator. You can get infections from being on a respirator. So really, we don't want them to be on a respirator for a long time. We want to wean them off of the mechanical ventilation as quickly as we can. All patients who have been diagnosed with ARDS, it's important to know that they should be getting a screen for a patent foramen ovale, and you do that with a two-dimensional cardiac echo. Certainly, you should be judicious with fluids. Now, of course, if the patient is septic, you have to make sure that you're keeping their blood pressure at a level where they can oxygenate their tissue. However, what you don't want to do is give them too much fluid, because what's the problem here is that you've got edema in your lungs. So if you're giving them too much fluid, you're just contributing to the problem. So you should err on the low normal side as far as fluids. Certainly make sure that their blood pressure is staying above 100/70, but don't go overboard on the fluids, because that's a very easy way to keep the patient on the respirator, to prolong their disease, and certainly increase their mortality, in my opinion. You want to follow their progress along with chest x-rays and ABGs. You want to also follow their progress with PaO2 FiO2 ratio, which is actually how we now define acute respiratory distress syndrome, and I'll talk about that on the next slide. They should also be on ICU and bed rest protocols. Usually patients with ARDS are put in the prone position, and other things are that you're giving them, a lot of times we give them some kind of an acid reducer or an antihistamine to reduce the risk of gastric ulcers, which they do have a risk of since they're being ventilated. And as far as the USMLE goes, do not give them steroids. Some physicians, some intensivists do give steroids, but as far as the USMLE goes, don't do it. There's no proof behind it. So there are doctors who do it. There's no data that shows that it's effective. Okay, so this PaO2 and FiO2, this is very, 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 very important to know about, and it's very important to know about in real life too, because this is how you're going to monitor your patient in a way that is mathematically, you can follow mathematically. So you can impress your attendings on wards with this information, because this is really the gold standard as far as following patients. So the PaO2 is the measurement on the ABG that indicates the partial pressure of oxygen in the blood. So you should know that what the PaO2 is. PaCO2 doesn't really play a role in ARDS. We look at our PaCO2 when we're talking about respiratory acidosis, but we don't really look at it as far as ARDS. So we're looking at PaO2. That's the measurement on the ABG that measures the partial pressure of oxygen in the blood. It's really a representation of how well we are getting oxygen across the alveolus into the capillary. The FiO2 is the fraction of oxygen in the air that the patient is breathing. So that is going to be normally 20%, because in the air, 20% of the air is oxygen, and that's just due to the world that we're in. 20% of the air we breathe is oxygen. So this is the minimum that the patient is going to breathe. When we give a patient a nasal cannula, we're giving them supplemental oxygen. So when you hear the word supplemental oxygen, that's be a nasal cannula, it can be a mask, it can be an intubation, but it gives them additional oxygen in addition to the 20% of oxygen that they're breathing. So I don't think the USMLE will give you this formula, and this is an easy, nice trick of the hand to know as far as the nasal cannula goes. So how do you know what the FiO2 is that they're breathing if they're on a nasal cannula? What you do is you look at the flow of oxygen. So with a nasal cannula, it can be 1 liters, 2 liters, 3 liters, 4 liters, 5 liters, 6 liters per minute. Whatever that flow rate is, you times that by 4. So if they're on 5 liters per minute, you multiply that by 4. That's 20. So you add that 20 to your original 20%, and that's 40. So if they're on 1 liter per minute, it's 24% FiO2. If they're on 2 liters per minute, it's 28%, 32, 36, 40. And then if they're on 6 liters per minute, 6 times 4 is 24. Add that to your original 20, and they're on 44% FiO2. So that's going to be very important to know, because generally when a patient is diagnosed with ARDS, the nasal cannula is what they're on. So you're going to need to know that FiO2 to make the diagnosis of ARDS. As far as PEEP goes, you adjust the FiO2 yourself, so it's pretty straightforward. You don't need to do any calculations. But remember to set it at the lowest FiO2 level so that you can maintain the patient at 90% saturation or more. So ARDS is defined by a PaO2 to FiO2 ratio. Yes, we do have a chest x-ray that shows infiltrates, but we don't really know if those infiltrates are due to cardiogenic pulmonary edema or due to ARDS or possibly due to something else. Yes, a PaO2 is helpful, but PaO2s can be dropped from a lot of different things. Really, the best way that we can define ARDS is by the PaO2 to FiO2 ratio. And all you're doing to determine this ratio is you're taking your partial pressure of oxygen, which is normally between 60 and 100, and then you're dividing that by your fraction of oxygen. So going back, if it's 40% FiO2, you're going to divide that by a 0.4. So you're going to express the FiO2 in decimal form, not in percentage. So you're not dividing by 40, you're dividing by 0.4. So you take your partial pressure of oxygen, divide it by your fraction in decimal form. Normally, the PaO2 to FiO2 ratio should be above 300. If it's between 200 and 300, that's considered mild ARDS. That used to be considered acute lung injury. Now it's considered mild ARDS. So anything below 300 is ARDS. 200 to 300 is mild ARDS. 100 to 200 is moderate ARDS, and less than 100 is severe ARDS. And you can see what are the things that are going to make this go down. Well, if the PaO2 is lower, that makes this fraction go down, and if the FiO2 is higher, that makes this fraction go down. And so that makes sense, because if your PaO2 is lower, that means your ARDS is worse, because you're not getting oxygen across. And if your FiO2 is higher, that means your ARDS is worse, because you're on a higher fraction of oxygen, and it's still not getting your PaO2 up to where it needs to be. So let's look at a little case study here to try to illustrate this. So a 76-year-old man is status post laparoscopic cholecystectomy, postoperative day 4. He complains of shortness of breath, dyspnea, and purulent sputum. His blood pressure is 130/90, heart rate is 105, temperature is 102.4, respiration is 18, saturation 78%. Physical exam reveals bilateral rales and bronchi. Nasal cannula is increased to 6 liters per minute, and 10 minutes later his saturation is 86%, where it remains. Chest x-ray is pending. ABGs reveal a PaO2 of 51 millimeters of mercury. Does this patient meet the criteria of ARDS, and if so, what level? Okay, so how do we do this? So we're going to take first our FiO2. So remember, with a nasal cannula, you just you take your liters per minute and multiply it by 4. So I arranged it here so it's in the decimal form already. So 0.20 is your room air. That's what you're always breathing. And then your supplemental air from the nasal cannula is 0.04 times the 6 liters per minute. So you're getting 0.44 fraction here. Hopefully I made that clear enough. So 0.44 is your fraction of inspired oxygen. It would normally be 0.2, but with the nasal cannula now you're getting 0.44 instead. Now we need to do our ratio. And our ratio is our PaO2, which is 51 millimeters of mercury, divided by our fraction of inspired oxygen, which is 0.44, and that comes out to be 115.9. And so this patient has moderate ARDS. And if you look back at our classification here, it does fall within this moderate ARDS classification. Okay, so you can look at this case study, see how we treat him. So he has moderate ARDS. Obviously, this is a patient with that level. He's going to need to be sedated. He cannot be kept at a saturation of 86 while he's got this disease. So he's sedated and intubated with PEEP, and the ventilation is set to FiO2 of 90%, which sustains his saturation above 90%. And of course, this is just to this patient. It could be any different level depending on the severity of their ARDS. Don't worry about the centimeters of water. That should actually say centimeters of water, not centimeters/water. Don't worry about the centimeters of water. It does correspond on ventilators to your FiO2. All you need to know is FiO2. Don't worry about centimeters per water. You will need to know that in real life, though. Don't worry about it for the USMLE. So his chest X-ray revealed left lower lobar consolidation transposed upon bilateral infiltrates. So he started on IV cefepime, linezolid, and ciprofloxacin, which would be your treatment for hospital-acquired pneumonia. We are concerned about MRSA here, so that's why we've put him on linezolid. We're also concerned about Pseudomonas. So we've got him on a whole host of antibiotics. And because he does have ARDS, we're going to err on the side of caution with our antibiotics. We're going to nail this thing because he has a quite possibly fatal illness here. Daily chest x-rays showed resolution. On postoperative day 6, he's maintaining 97% saturation on an FiO2 of 65%. So look at that. That's where we should be. He was intubated on postoperative day 4. 2 days later, he's maintaining saturation at 65% FiO2. And if you do your ratio again here, you've got a ratio of 150. Not quite healed yet, but he's making the right progress. By postoperative day 12, which would be approximately the end of his antibiotics, the patient is maintaining 93% saturation at an FiO2 of 40%, and that's a ratio of 233. So now he's moved into mild. And the magic number of that FiO2 of 40% is that that's where we can extubate. We can take him off the PEEP and put him back onto the nasal cannula. Because if you have a patient on 5 liters on their nasal cannula, remember the formula, 5 times 4 is 20, and add that to the original 20 on room air, and that's 40. So you're going to get the patient on the same amount of oxygen on 5 liters per minute of nasal cannula as you would have them on an FiO2 of 40% with PEEP. So we would prefer to have them on the nasal cannula if we have the choice between the two. So we extubate at 40% if we can keep them above 90% saturation. We extubate them if they can keep themselves up there at an FiO2 of 40%. The patient was then extubated, placed on 5 liters per minute nasal cannula, and ultimately discharged on postoperative day 7. But you can see here that he was in the hospital for a long time, and this is a very significant problem. So ARDS is a very serious disorder, and the mortality is 27%, even just with that mild ARDS. With severe ARDS, it is up to 45%. This is based on the Berlin criteria, which is the brand new criteria that just came out last year in 2012. And remember, that is mild being 200 to 300, moderate being 100 to 200, severe being less than 100. And if the ARDS is coexistent with sepsis, reportedly the mortality can be as much as 90%. And on that grim note, that's the end of ARDS.